Good afternoon, and welcome to the second medical update of this year. Today's web-based seminar is called TB Technical Instructions for Panel Physicians, Implications for U.S. Practitioners. My name is Eileen Napolitano, and I am the Deputy Director at the New Jersey Medical School Global Tuberculosis Institute, the sponsor of today's program. Each year, approximately 400,000 immigrants and 50,000 refugees enter the United States. The technical instructions, initiated in 1991, contain the requirements for overseas medical evaluation, including tuberculosis screening. The technical instructions were updated in 2007 and have important implications for U.S. practitioners. The objectives of this webinar are listed on this slide. In this seminar, you will learn about the purpose of the TB technical instructions for panel physicians and how and why they have changed. Upon completion of this seminar, participants should be able to describe the purpose and use of the TB technical instructions in the medical evaluation of persons emigrating to the United States, list the changes to the TB technical instructions to clarify their use in the examination of immigrants and refugees, explain how to implement the TB technical instructions to appropriately provide related medical consultation, and apply the TB technical instructions to the medical follow-up of immigrants and refugees arriving in the U.S. Our faculty today are Mr. Phil Lowenthal, Dr. Sundari Mace, and Dr. Drew Posey. The seminar today will consist of several parts. After this introduction and some brief housekeeping details, Dr. Mace will start us off with a background and overview of the TB technical instructions. Then Dr. Posey will talk about the implementation of the technical instructions. We'll then hear again from Dr. Mace with several cases to illustrate some of the important points from the technical instructions. And finally, Mr. Lowenthal will join us for the discussion session in which you may share your thoughts and ask questions. Our first speaker is Dr. Sundari Mace. Dr. Mace is the team lead for medical affairs in the Field Services and Evaluation Branch at the Division of Tuberculosis Elimination at the Centers for Disease Control and Prevention. She will be providing an overview and background of the TB technical instructions for panel physicians and will highlight the recent changes. Dr. Mace, I'll turn it over to you.
Great. Eileen, thank you very much. Okay, well, over the course of the next 15 minutes, what I'd like to do is to briefly describe what the reasons were for changing from the 1991 TB technical instructions to the 2007 Culture and Directly Observed Therapy TB technical instructions, and to note what those changes are. So as Eileen mentioned, each year there's approximately 400,000 immigrants and 50,000 refugees that enter the United States. The Division of Global Migration and Quarantine has the regulatory authority to stipulate the requirements of the overseas medical examination via these technical instructions that apply not only to tuberculosis but to other diseases. The Bureau of Populations, Refugees, and Migration is a State Department bureau that's responsible for refugee resettlements. And BPRM has contracted the International Organization for Migration to perform medical screening for about 80% of the refugees, and perhaps even a greater percentage now. So the initial technical instructions for tuberculosis screening were issued in 1991. And really the rationale for overseas screening is specifically to screen TB suspects using these technical instructions to restrict the entry of infectious TB cases, but to facilitate entry of the rest in a very seamless fashion with evaluation treatment per our guidelines, the ATS, CDC, IDSA standards. And then for the U.S. Health Department to follow up evaluation and treatment of non-infectious cases, and that is cost-effective on the state side. So what triggered the need for revisiting the TB technical instructions? Well, in December 2003, the U.S. Department of State approved the resettlement of about 15,000 Laotian Hmong refugees to the United States. Medical screening started in February 2004, and refugees began arriving in June 2004. 6 months after refugees began arriving, CDC was notified of 31 active TB cases in this population in California out of approximately 6,000 refugees, giving a case rate of 700 per 100,000, compared to the U.S. case rate of under 4 per 100,000. 50% of these cases were culture confirmed with multi-drug resistant TB. The resettlement was halted, and there were investigations performed simultaneously by CDC in Thailand and in California. This is a picture of Wat Tom Krabat, which is where many of these refugees were residing at the time. So let's review the TB technical instructions from 1991. Prior to the 2007 instructions, there was no requirement for TB skin testing, and chest x-rays were only performed in those greater than or equal to 15 years of age. Smear microscopy was performed, but no culture, and there were limited requirements for TB treatment overseas. Directly observed therapy was not specified. In fact, once a patient became AFB smear negative on TB treatment overseas, they were allowed to travel to the United States to complete their treatment. So here is the 1991 technical instructions. And so a chest radiograph was performed, and based on the chest radiograph for those greater than or equal to 15 years of age, patients were either thought to have inactive TB, active TB, or no TB. And as we all know, it's very hard to tell inactive from active TB just by a radiograph. So at that time, if the physician screening the patient thought that the chest x-ray was consistent with inactive TB, the patient was given a Class B2 status, and this was valid for travel for 6 months. And if they were felt to have active TB, then of course they gave 3 sputum smears only. If the smears were negative, they were considered to have non-infectious Class B1 status. If at least one of these smears was positive, they were thought to have infectious Class A status. And then, of course, based on an X-ray, if it was completely normal, they were felt to have no TB, given no classification, and travel was valid for 12 months. And again, as I mentioned, these Class A patients had limited treatment requirements overseas until considered non-infectious by negative smears, and then were able to travel once considered non-infectious. Clearly, in this process, there is the risk of missing active TB in several levels. First of all, if a chest X-ray was determined to be consistent with inactive TB, a patient could still have active TB, they simply wouldn't have had an evaluation. As I said, you can't really tell active from inactive TB based on the radiograph. And then, of course, the validity periods of 6 and 12 months give plenty of opportunity for a patient to potentially become infectious with active TB in those time periods. And the lack of sputum culture requirement missed a lot of cases in this algorithm. So the technical instruction revision really began in 2005. Scientific literature was reviewed. There was input from a TB technical instruction working group consisting of TB experts from around the country. And just as background, as we know, 1/3 of the world is latently infected with the organism. There's approximately 8 to 9 million cases of active TB reported to WHO annually, and somewhere around 1.8 million deaths reported to WHO annually. This slide I put in just to show that TB case rates are very high in countries from where our immigrants and refugees are coming, and that's one reason why to really focus on screening these folks overseas before arrival. And again, data showing that the TB numbers of cases and proportion is increasing steadily over the years, and that again has supported the need for enhanced screening in this population. A study that was done in Vietnam looked at what the sensitivity of the 1991 TB technical instructions were for picking up active TB by looking at approximately 1,180 patients that had abnormal chest radiographs, obtaining both smears and cultures on these patients. Based on smears alone, 82 patients were determined to have active tuberculosis, 7%. But when cultures were added, 183 additional patients were found to have active TB, doubling the number that, or actually tripling the number that would have been found with just smears alone. So the sensitivity of the 1991 technical instructions was found to be woefully low at 34%. Approximately two-thirds of TB cases were shown to be missed by not obtaining cultures. And the reason that number is so high in this population is because it's active screening. Most of these patients were not sick or symptomatic, so they were less likely to be smear positive and culture positive. So here's who was involved in the revision, the collaborators for the revision of the TB technical instructions. And here are the basic changes that were made. It was determined that tuberculin skin test or an IGRA test should be performed in applicants 2 to 14 years of age in countries with WHO estimated TB incidence rates of greater than or equal to 20 per 100,000. And a chest X-ray would be required if the tuberculin skin test was greater than or equal to 10 millimeters, or if the interferon gamma release assay was positive. In addition, 3 sputum cultures were made a requirement in addition to smears for any applicant with an abnormal chest X-ray. Drug susceptibility testing was a requirement, made a requirement on any positive cultures, given that there was so much resistance found in certain populations that are screened overseas, depending on the country of origin. Directly observed therapy was made the standard of care for treatment of these patients once diagnosed with active tuberculosis overseas. And if drug resistant, the Francis J. Curry International Center's drug-resistant TB guidelines were to be used for the treatment of these cases. The validity period of the medical examination was also decreased because, as I said, the likelihood a patient might progress from from being latently infected to having active disease, or from being smear negative to smear positive, is great within a 6 or 12-month period of time. So the validity period was decreased to 3 months if the patient was felt to have class B1 TB or was HIV co-infected, and 6 months otherwise. So nobody could have a validity period of 12 months any longer. Children 10 years of age or less would be allowed to travel while TB cultures were pending if they did not meet criteria for infectiousness. And applicants who had TB treatment at a non-CDC approved site, in other words, a private hospital or another facility but not one of the panel sites, needed to provide specific treatment documentation by directly observed therapy, and would have to wait 1 year post-treatment to undergo a repeat immigration medical examination. So really a disincentive to not being treated by a CDC-approved site. And basically, no treatment equals no travel. So a patient has to be treated overseas to treatment completion if they want to come essentially to the country. So let's take a look at this, kind of a bit of a summary of what I've already said, but so that it's very clear what we're talking about. In WHO TB incidence countries of greater than or equal to 20 per 100,000, those patients 2 to 14 years of age would have now a skin test or an interferon gamma release assay. If less than 10 millimeters, or if the IGRO is negative, that patient would have no TB classification and could travel within 6 months. If, on the other hand, the skin test was positive, greater than or equal to 10 millimeters, or the interferon gamma release assay was positive, the patient would then get a chest X-ray, which is a big difference from the previous 1991 technical instructions. If the chest X-ray is considered completely normal, then the patient would get a classification of B2 status, meaning that they were felt to have latent TB infection and would be flagged for evaluation stateside once they arrived in the United States. And again, those who are HIV co-infected, or HIV infected, I should say, needed to travel within 3 months, just given the increased potential for progression to active disease. If the patient had signs or symptoms, or the chest X-ray was abnormal in any way, or if they had HIV infection, then they would need to give 3 sputum smears and cultures, and if they were all negative, that would include the cultures. The patient would have a classification of class B1 TB and would be followed up and could travel within only a 3-month period. If any of the smears were smear or culture positive, that is, any of the specimens, then the drug susceptibility testing would be performed on the positive culture, and the patient would need to be treated to ATS, CDC, IDSA guidelines by directly observed therapy until therapy is complete, and would then could travel within that 3-month period. So quite different from the 1991 TIs. Now, looking at the same algorithmic process for those greater than or equal to 15 years of age, there would be no treatment or testing for latent TB infection. Rather, they get a chest X-ray, and again, the same algorithm. If normal, travel within 6 months, signs or symptoms, abnormal chest X-ray or HIV infection, they would give 3 sputum smears and cultures. If all negative, class B1 TB. If any smear was positive or culture positive, then again they'd be treated by our standards by DOT until therapy was complete. And again, then after therapy complete, could travel then within the 3-month period. And this just is for your own reference, stating exactly what I've said, showing the algorithm altogether. Again, in WHO TB incidence countries that had a rate of greater than or equal to 20 per 100,000, that's when the kids would get the TST or the interferon gamma release assay. So then basically this then summarizes the travel validity periods, and again summarizes that if the TB rate is greater than or equal to 20 per 100,000, the children between 2 and 14 would have TST or interferon gamma release assay. If it was positive, then a chest X-ray. If the patient was HIV infected or had TB signs or symptoms, again, they'd get a chest X-ray. And if abnormal, they would have 3 sputum smears and cultures. If all negative, class B1. If one or more are positive, considered to be class A, and they'd have DOT, treatment under directly observed therapy until cured. They could potentially qualify for a class A waiver, which when we listen to the cases, I'll get into that. This is actually our classification slide, just showing what the classes are now. So if a patient had a negative tuberculin skin test or a normal chest X-ray and those greater than or equal to 15, they'd have basically no classification. If they are found to have TB disease, they're considered class A. If they had an abnormal chest X-ray with sputum smears and cultures negative, they'd be considered class B1 pulmonary, still need to be followed up on arrival. If they had extrapulmonary tuberculosis, then they're considered non-infectious, and they'd be classified class B1 extrapulmonary and actually could travel because they're non-infectious. If in the children who had tuberculin skin testing or interferon gamma release assays, if they were found to be positive on either of those tests, they'd have a class B2 status, and again be flagged for follow-up once arrival in the United States. And then the last thing is class B3 refers to those who are contacts to infectious TB cases, and these people, perhaps family members, would then be flagged as class B3 and would need to be followed up also upon arrival. And another big part of the new 2007 TB technical instructions is the requirement for directly observed therapy, which did not exist in the 1991 technical instructions. And as we know, DOT is an adherence-enhancing treatment strategy and is considered the standard of care for TB treatment here in the United States, where a trained healthcare worker monitors a TB patient as the patient takes every dose of anti-TB medication, checking clearly for side effects to medications prior to administration, and checking to ensure that the patient actually ingests the medication without cheeking or spitting out or any other process. So under the culture and directly observed therapy, TBTIs, directly observed therapy must be administered when TB disease, that is class A condition, is present. Even if it's a clinical diagnosis, if the patient's under treatment for active tuberculosis, they'd be required to have directly observed therapy. So in summary, comparing the 1991 TB technical instructions with the current culture and DOT TB technical instructions. No skin testing was performed in 1991. There was no requirement. And now we do have a requirement for those patients ages 2 through 14 if the country TB rate is greater than or equal to 20 per 100,000. Chest X-ray was required for those greater than or equal to 15 years of age. And here, chest X-ray is required in that category, as well as if a patient has a positive test for latent TB infection. In the 1991 technical instructions, there was only a requirement for smears. Now, culture and drug susceptibility testing has been added for 3 specimens. There was no requirement for directly observed therapy in 1991, and now there is, using United States guidelines until treatment is completed. The validity period was 6 months if Class A or Class B back in 1991, and now is shorter. Again, here the classes are similar. Class A, you can't see the A, but no classification if there's a normal evaluation. Class A if there's TB disease. Class B1 pulmonary essentially is the same, except that now cultures have been added if cultures are negative. Class B1 extrapulmonary remains the same. Class B2 now used to refer to inactive tuberculosis on chest X-ray, which of course we discussed is a bit of an anomaly since it's difficult to call tuberculosis inactive based on a chest X-ray alone. Now Class B2 refers to latent TB infection and the requirement for evaluation. Class B3 used to refer to old or healed tuberculosis, again, a bit of an anomaly, and now refers to a contact that needs to be evaluated. So the key points to remember are that the culture and directly observed therapy TB technical instructions are really designed to improve overseas TB detection and decrease importation of TB into the United States. Implementation is occurring now and must be uniform. And Drew Posey from the Division of Global Migration and Quarantine is going to speak more about the implementation in just a minute. So here's the link for the TB technical instructions, and I will stop there, acknowledge these folks for my slides, and turn this over to Drew.
This is Eileen. Thank you, Sundari, for that excellent review of the background information and for sharing the rationale behind the changes to these guidelines. Next, we will hear from Drew Posey, Dr. Drew Posey. Drew is the team lead for medical assessment and policy in the Immigrant, Refugee, and Migrant Health Branch at the Division of Global Migration and Quarantine in the Centers for Disease Control and Prevention. He will be talking about how the technical instructions have been implemented thus far and the processes behind this rollout, both here and abroad. Drew, we'll turn it over to you.
Well, thank you for the opportunity to discuss this, and I think what Dr. Mace did was wonderful and helped set this up, and so I'm going to now focus on the implementation effort of these technical instructions that Dr. Mace just went through. And I'll begin by giving a little sense of the fact that this has been a phased implementation effort over the last several years once these new instructions were developed and first started to be implemented in 2007. And as we've worked to phase it in, we've based our plan around to prioritize based on factors such as the number of immigrants and refugees arriving in the United States, the source country's tuberculosis rate, and source country's contribution to the United States tuberculosis rate. As alluded to, we think that this implementation effort can provide some benefits in the source countries to help develop culture and directly observed therapy infrastructure, as well as to help link panel physician programs with broader control efforts. And we think that this has some benefits for the United States, particularly to help lower the tuberculosis rate and reduce transmission, particularly in the foreign-born. To provide a sense of volumes and perspective, this is a graph showing the arrival flow of legal permanent residents to the United States over the last 112 years. And as I think we're probably all familiar, for our legal permanent resident arrivers each year, we're referring to status adjusters, persons who are already living in the United States and then try to adjust their immigration status. Those are persons who are examined within the United States by a civil surgeon. And we're also referring to entrants, which are your persons arriving on an immigrant visa or a refugee. And those are the persons who are screened overseas by panel physicians. And among those entrants, 4% arrived with a B classification in 2011. And so roughly, out of the roughly 1 million each year, about half are persons examined overseas, which has been the focus of this implementation effort and these panel physician culture and DOT TBTIs. So overseas, there are 369 panel physician sites located in 151 jurisdictions or countries. The CDOT TBTIs, or the TBTIs we're referring to, have been implemented in 64 jurisdictions. There are 620 panel physicians worldwide, and CDC has been able to visit approximately 20 countries per year during this implementation effort. And the map on the screen, the dots are for each panel physician site around the world. So when we say that this has been implemented in 64 countries, this translates to 77% of immigrant visa entrants arriving to the United States have been screened according to the culture and DOT TBTIs. It also means that about 77% of U.S. diagnosed foreign-born cases were born in countries where the TBTI have been implemented, and about 90% of the persons arriving in which there is a TB notification done, and we'll talk more about the notifications to receiving health departments later on, but 90% of the persons arriving with a TB notification are from countries where the TBTI have been implemented. This map shows you where around the world the screening is currently being done according to these new technical instructions. The countries are in red are where it has been occurring, and I think we can see a lot of countries that we're very familiar with when we think about U.S. foreign-born TB control, but many others, and ultimately, as we'll discuss, this does have to be put in place around the world such that the whole map, except for the United States, because that's where they're coming, should be red. So when we implement these technical instructions, we have a certain overarching strategy that we try to follow, and in particular when it comes to site visits. When we undertake a site visit to a country that is not yet screening according to the new TBTIs, we want to evaluate and teach the panel physicians on the new instructions, inspect candidate laboratories as well as candidate DOT sites, and meet with tuberculosis officials. It may be National Tuberculosis Program officials, but within countries, we try to identify who is active in tuberculosis and try to build relationships with them in order to accomplish the implementation. We work to educate the consular section staff members because they're the ones involved with the panel physicians and the applicants from the embassies for their immigration work. And then develop an implementation plan and perform focused follow-up as needed to carry that plan through to implementation. So let's look at the two big key areas as Sundari talked about, the laboratory and the treatment components. So for laboratory, this is actually a picture on the left showing a technician in Vietnam, one of our largest source countries, inspecting a sputum specimen that's been provided. And also in the upper right, many of you may recognize that as a liquid culture machine known as a Bactec Midget 960 that's formed. It's been a real workhorse and a backbone of many of the laboratories that have sprung up to help support this effort. So we face some challenges around the world on the laboratory front. Around the world, many national TB programs, for their national guidelines and policies, have a lack of a requirement for cultures as a standard of care. So some of these bullets may seem a little redundant, but they follow one another. With the lack of requirement for cultures, there's a subsequent lack of culture laboratories, and from a lack of culture laboratories, we find a lack of quality culture laboratories to be able to support this work. And it also stands to reason then, we've also experienced a lack of second-line drug susceptibility testing related to a lack of capacity up front. So to try to address that, in addition to partnering with different organizations and trying to build these relationships, there have been new laboratories developed around the world performing solid and liquid cultures, and in some instances, second-line drug susceptibility testing in order for these panel physician sites to fulfill the requirements of these technical instructions. So you see on the slide, the new laboratories were developed in China, India, Kenya, Malaysia, Mexico, Nepal, Thailand, and Vietnam. These have been some of our largest source countries through the years, as well as some countries that have really had a very high burden of tuberculosis in their screening populations. There were some other laboratories that, while they may have been in existence, they were really revamped and capacity greatly increased. And as I mentioned a second ago, there's a few laboratories that are now performing second-line DST, and this influx in infrastructure around the world and having laboratories move to second-line DST is something we're really proud of and excited about, and we think this really is helping make a great contribution for our screening programs, but also can have other benefits that we'll allude to in a slide later on. So let's talk about treatment for a second. These pictures are from showing some refugees receiving treatment for tuberculosis, and I believe these are in Thailand in a Burmese refugee camp at a DOT site managed by the International Organization for Migration. We've found numerous challenges with DOT, such that in many countries, but not all, but in many, it has been easier to implement the laboratory component than the treatment component. In many countries, directly observed therapy just may not exist, and that may not exist as a standard of care. We find issues with first-line therapy. There still are national TB programs that use an 8-month regimen for first-line treatment. What I'm specifically referring to there is the initiation phase may be similar to what we use in the United States, but then they follow that with a 6-month continuation phase of isoniazid and ethambutol. The WHO recommended this no longer be used, I think now a couple years ago, and I was actually tempted to remove this from this slide, but we had a site visit to a country a couple of months ago where they actually went to a proposed directly observed therapy site with the National TB Program and found boxes of isoniazid ethambutol combination pills that were well within the expiration date and currently being used for treatment. So it is still being used. For second-line drugs, we have seen some big challenges. As many of you may know, there are limited manufacturers for second-line drugs and limited supplies. And I know that in the United States, we've at times seen limitations in supplies of certain drugs. So that is definitely seen overseas. As we all know, some of these drugs are very, very expensive. And interestingly, some countries' own national TB programs or ministries of health may have import restrictions. MDR TB expertise can be lacking, and there's been issues maneuvering with the Green Light Committee on some of this through the years. Through all of this, we have worked hard to try to forge linkages between the screening programs and in-country efforts. We have tried to be very aggressive about this because we believe that if we can improve screening for U.S.-bound populations, that can be great and wonderful as it pertains to identifying and treating TB in those folks. But we're cognizant of an increase in TB infrastructure and expertise through this effort, and we want this effort to be able to link with broader control efforts because we believe if this can make a contribution to in-country efforts, then in some small way we can begin to make a contribution more broadly, and in the long run, if TB control is improved within source populations, that helps TB control in the populations coming then to the United States. There was an article a few years ago where Kevin Schwartzman was the lead article that talked about that concept, and investing in TB control in source countries in the long run could yield a greater return on investment than merely fine-tuning screening programs. So we try to forge these linkages. I'm not going to go over all of them, but we've seen some great things such as a novel public-private partnership in the Dominican Republic between the panel site and the National TB Program there. IOM has been a great help in some cities, working with NTPs and actually helping import second-line drugs. And we've even seen, for refugees coming to the United States from Nepal, a camp-wide tuberculosis program where not just the refugees coming through the screening programs are receiving these types of services, but the entire camps have access to a culture-based DOT system for TB control. We've talked about some of the challenges implementing, and I've highlighted we see a lack of standard of care in many countries with things like cultures or directly observed therapy. So because of that lack of standard of care, we come across many folks who aren't familiar with more of this type of rigorous approach to tuberculosis. And so whether to address that or just to educate people on the technical instructions themselves, we've worked hard during this time period to really establish and develop a comprehensive education program for panel physicians. And it's involved many entities, including in the first bullet, to help address the basic tuberculosis education deficit we've seen in some countries. The RTMCCs began allowing panel physicians to attend the clinical intensive courses, and this has been really widely appreciated, and we've always gotten great feedback on this, and we think this has been wonderful for panel physicians to come to the clinical intensive courses and be able to receive education firsthand on the types of things that really underlie and help drive the development of these technical instructions. We started holding training summits around the world where panel physicians could come in and receive training over a few-day period. We've held 9 of these beginning in 2008. The International Panel Physicians Association, which is an association to represent panel physicians, was formed over the last few years and has become a partner in these. And Celestis has also been a co-sponsor. We've had webinars, including 2 most recently. We developed a LinkedIn site. On our website, there's a panel physicians portal to try to crystallize and organize information in an easy way for panel physicians. We have an online training module in development, and also we provide training directly for the consular officers, given their unique and key role. For the overseas training summits, I want to walk through the next several set of slides, which is a time lapse showing the coverage we've been able to achieve in terms of countries that have had personnel come to a training. And again, this is something we're very excited about and proud of. So our first one was held in 2008 in Jordan. Then in 2009, we held training summits in Nairobi and Manila in the Philippines. In 2010, we held training summits in New Delhi, Ghana, and the Dominican Republic. In 2011, we held summits in Thailand and Peru. And earlier this year, we've moved to a yearly model. We held one in Istanbul, Turkey, to try to pull in more folks from Europe and the Middle East. So you can see, and again, we're very excited about this, that we've had, over this implementation time period, panel physicians and consular officers, both from IOM and non-IOM on the panel physician side, come to these training efforts from all the countries you see in red. And we're continuing to work on how we can improve on this and get even greater attendance. I mentioned earlier on the treatment issues a lack of MDR TB expertise. Well, as we put this in place, it was recognized early on that the physicians need to have a way, a lifeline, if you will, on difficult cases, whether they be drug resistance or just complicated clinical scenarios. And we've been able to work with the DTBE and the RTMCCs on setting up a clinical consultation system whereby the panel physicians can access the network through the RTMCCs that physicians in the United States access. We think this has been a really outstanding and wonderful service that's been provided, and a wonderful lifeline, if you will, for the panel physicians. And you can see over a couple-year period since this got going, a large number of consultations from a wide variety of countries. And it's striking to me, of the 53 during that time period, almost half are for MDR TB. I think really underscoring the importance of this service and how valuable it is, and why we get great feedback from panel physicians on it. So, but once this is implemented and things are in place, that doesn't mean our work is done. We do try to do different things to keep tabs on it and make sure there's good follow-up and evaluation and monitoring activities. And so we certainly conduct follow-up visits when needed. But another thing I want to highlight is on-site, really in-depth, thorough TB evaluations that have been led by representatives of ACED and NTCA. These have been widely successful. First one was in IOM in Thailand in 2007. We've now done 5. The Santo Domingo, Dominican Republic one just concluded a month ago, or earlier this month actually. We have found these to be invaluable from the DGMQ perspective to learn more and gain better insights into what we can do on these programs, but especially for these programs themselves to have this caliber of experts to come in and work with them and evaluate them and teach them. And I think it really helps bridge the understanding between the panel physicians and what folks stateside may be really interested in, as well as for the folks stateside to have the access to these programs overseas and get a feel for what they're doing. And so evaluation and monitoring activities are definitely something we work on, and I'm hopeful as the years go by we can continue to do more of these types of evaluations. So how is this going, and what does it mean, so to speak? Well, to give you a sense of how the data has shaped up, this is a slide from the Philippines, one of the largest panel sites in the world, and the Philippines is one of the top source countries for immigrants, as many of you know. And this is a slide that compares the fiscal year before they implemented and the fiscal year after they implemented. So they started screening according to the new instructions on October 1st, 2007. And so before then, they were not doing cultures on persons who were smear negative. So we see, I want to draw your attention on the graph. You'll see the smear negative culture positive row where you see 306 in red, meaning the first year of screening they identified 306 people who were smear negative but culture positive. And compared to the smear positive and culture positive row of 102. And that dramatic increase, roughly a 3-fold increase in yield, is consistent with the data that Dr. May showed from the study in Vietnam and is a pattern we see replicated in many, many countries. But this shows the tremendous increase in yield that can occur by moving to this culture-based system. So someone could ask, well, that sounds great. Does that have an effect stateside? And Phil Lowenthal was the lead author of a study that came out a couple years ago where in California they looked at persons arriving to California from Mexico, the Philippines, and Vietnam, and they looked at those arriving with a B1 classification and their rate of tuberculosis before and after implementation, meaning when they had their follow-up exam, what percentage were diagnosed with tuberculosis. And what this graph shows is that before the TBTIs were implemented, because this was implemented in October of 2007 for Mexico and the Philippines and February of 2008 for Vietnam, we see the rate of diagnosis post-arrival around the 3.5 to 5.5 percentage range. And then after it was implemented in these countries, we see it fall, and now it's hovering in the 0.5 to 1.5% range. A decrease. We're very excited about this. This is one of the things that, for us, is what it's really about. Being able to not just find these people, diagnose them, and treat them, but see the gain in TB control stateside. In Minnesota, they did an analysis that looked at how their foreign-born epidemiology has shifted, and they find some decreasing rates of diagnosis in their populations coming in among their immigrants and refugees. So we're very excited about that. So aside from seeing some changes in the epidemiology and the case detection rates, we do think this can have an economic, or is having an economic impact, and is providing some cost savings to U.S. domestic programs. When we look at our programs around the world, and we have something called TB indicators where we require them to tell us the number of cases they're diagnosing, we know that they're diagnosing over 1,000 persons worldwide with culture-positive tuberculosis amongst all these screening programs. if 4% of those are MDR-TB, that would be about 40 MDR cases per year. So when we think about that and we look at costs of treatment in the United States and some of the published figures, we do believe this is a cost savings or perhaps cost aversion of upwards of $13 to maybe more than $30 million per year by this increase in detection and treatment overseas and freeing up those funds to be used elsewhere or for other important activities at the receiving health departments. And I say it that way because everyone's tight for funding right now, but we do feel this is leading to some significant cost savings as we get these people diagnosed and treated overseas. So we're very excited about this program, but we do feel we've come to a point where we needed to figure out and be working on how to wrap it up or close it out. And as we think about closing it out, we want one global standard for screening requirements for all the populations coming to the United States. We want to complete the gains in U.S. TB control among the foreign-born that can be achieved through this program. We want to do this in a way that maintains CDC leadership in global TB control. And so we worked on developing a closeout strategy where all panel physician programs would be screening according to these technical instructions by October 1st, 2013, or basically the first day of fiscal year 2014. In working with the Department of State over the last several months on trying to develop a strategy, the Department of State issued a cable, which is their method of communicating with the embassies and consular sections around the world. And that cable was issued on August 30th of this year, stated that all panel physicians worldwide should begin screening according to the culture and DOT TBTI as soon as able and no later than October 1st, 2013. That date was selected because it would provide a concrete end to the implementation plan. We believe this is achievable given the progress that has been made thus far. It provides the implementing countries at least 12 months to transition, and that's at least 12 months at the time of this announcement in August. And it's the beginning of a new fiscal year for the U.S. government. For many embassies, the start of a new fiscal year provides a good time for them to have new things begin. So during this fiscal year, our division has a very aggressive travel schedule for the remaining countries, again based on immigrant and refugee volumes and TB burdens. And also, we can't underscore the importance of our training activities as a way to help the remaining countries, whether that be through webinars, which we've already done for panels and consular officers on this, the Panel Physicians Portal to help disseminate information. And for the training summits, next year we're going to have our 2013 summit here in Atlanta, Georgia, March 4th through 8th. And we're already seeing good turnout. As of today, we already have more than 50 panel physicians who've already registered to date, which we're really excited about given we're still 3 months away from the summit. So, to change gears slightly, we've mentioned a few times notifications to receiving health departments, and that is done through our electronic disease notification system. And so EDN, as we call it, is created because DGMQ has a regulatory responsibility to provide information to receiving health departments of arriving aliens with a notifiable condition. And so EDN is the electronic system to fulfill this regulatory responsibility. For many of you who've been doing this work for a few years, you probably recognize that EDN replaces a previously used paper-based immigrant and migrant populations, or IMP or IMP system. But EDN has a couple features that we really like. It provides you access to the recorded DS form information as well as all scanned overseas DS forms. DS forms being the paperwork that the panel physicians complete on their examination. And it also provides health departments with an electronic system to record and evaluate the outcome of the domestic follow-up evaluation. And that, I think, particularly as we now start to think about the impact of these technical instructions, that follow-up data in EDN just becomes more and more important as time goes by. So this is a schematic that helps show how the process works. So overseas, panel physicians perform the screening of the applicants for immigration, the immigrants and refugees, and they complete the DS forms, the overseas forms on the slide. The immigrant or refugee arrives in the United States. That paperwork is routed to quarantine station officials who send it via FedEx each night to the EDN Data Entry Center here in Atlanta. There is also, as some of you may be aware, an interface with IOM so that we get some records electronically for those persons whom IOM examines overseas. That also makes its way through that interface to the Data Entry Center. And then the information is transmitted electronically to the receiving health departments. And then when the follow-up examinations occur, the information from those examinations is fed back into the EDN system. And finally, we've mentioned the bulk of this presentation from Dr. Mace's portion going through the technical instructions and my portion talking about implementation is dealing with the overseas medical exam or the examination performed by panel physicians. But we did want to mention there is the other path for immigration, the status adjuster path, where those persons receive their examination in the United States by a civil surgeon, and they do have a set of technical instructions that they follow. There are some similarities. A few years ago, a new set of civil surgeon technical instructions went into effect. Dr. Mary Knott, a senior medical officer at DGMQ, led that effort and got input from DTBE and the TB community. And likewise, it helped transition to using modern standards of care, requirements for cultures, and also updated guidance regarding LTBI infection. At that time, we worked on some issues with USCIS, but these have been in effect since 2008. All right, and that is all the slides I have.
Okay. Thank you, Drew, for your excellent presentation on the implementation and rollout of the technical instructions. We will now turn back to Dr. Sundari Mace, who will present some case examples for us. She will also ask a few questions, which will require you to answer questions online. Sundari, I will turn it over to you.
Great. Thanks very much. So what I wanted to do was just to give a few examples of some cases that Drew mentioned that the regional training and medical consultation centers that are CDC funded are now providing consultation to panel physicians overseas for complicated, challenging, or drug-resistant cases. And I have two examples of such consultations that have happened in the last few years since we've implemented that program. The consultation service is similar to the consultation provided for domestic TB cases, and any question can be asked, but we're finding that the questions that we're getting from overseas panel sites are generally entail very complicated or MDR, XDR type cases, and I'll give an example of two of those. And then I also want to give an example of a situation in which a Class A waiver has been granted for a patient to come to the United States despite being on TB treatment for active TB disease. And we at Division of TB Elimination work closely with the Division of Global Migration and Quarantine to hear these cases and try to help make a determination of whether the patient is infectious or not and whether there are extenuating circumstances that would compel the patient to arrive or come to this country before TB treatment is over. And generally it has to do with whether they would get better or would get optimal care here with expert consultation for very challenging cases. So anyhow, let me go ahead with case number one. And there will be a few questions. Some of them are treatment related, and please feel free to answer if you'd like. So case number one, these are a consult case that came into one of the regional training centers. So this is a 32-year-old Vietnamese female, a visa applicant with no prior history of TB that had no signs or symptoms of TB. Again, this is active screening, so often these people don't have signs or symptoms of TB. Here's her chest x-ray, and as you can see, she has significant right upper lobe disease, possibly cavitary infiltrates, possibly a right lower lobe infiltrate as well. So a chest X-ray that's pretty much consistent with TB. She had 3 AFB smears and cultures that were positive on October 12th, 13th, and 14th of 2011, and was referred to the panel site hospital for TB treatment by directly observed therapy. So she was an immigrant visa applicant, and it was the panel site physician that consulted the Regional Training and Medical Consultation Center. She was started by the treating physician in Vietnam on a standard 4-drug regimen per our standards. Shortly thereafter, DSTs for first-line drugs showed resistance to isoniazid and streptomycin, but the isolate appeared to be susceptible to rifampin, ethambutol, and PZA. The isoniazid was appropriately stopped in December 14th of 2011, but she had persistent positive cultures for 5 months. So she did not culture convert on an appropriate regimen for INH-resistant disease. So go ahead and feel free to ring in. What would be your next steps? Would you repeat first-line drug susceptibility testing, given that she's still culture positive? Repeat first-line testings and perform second-line drug susceptibility testing? Do both 1 and 2 and start an expanded MDR regimen? Or do 1 and 2 and perform some sort of a PCR-based test looking for mutations conferring resistance? So there's no right or wrong answer necessarily to this. It's just to get us thinking about it. Certainly when someone is still culture positive 5 months after being put on what we consider an appropriate treatment regimen, it's worrisome that something isn't right, that either there's further resistance that hasn't been detected, or that the patient's maybe not absorbing meds right, taking the meds appropriately, or something else is up. So any one of these answers would be appropriate. I see that most people thought they would repeat first-line DSTs, perform second-line, and start an expanded regimen. So let me go on and state, again, things aren't not always done overseas the way that we would do here. So this facility, this panel site, has the option to get a rapid test for drug resistance testing based on mutations, PCR-based assays. So this doctor sent the specimen for the Hain genotype MTBDR plus assay and found that there were mutations associated with both isoniazid and rifampin resistance on January 31st, 2012. And then he also repeated the first-line drug susceptibility testing, but the phenotypic results showed just resistance to isoniazid and streptomycin, and the isolate was still susceptible to rifampin, ethambutol, and PZA. So basically a discordance between the genotypic and the phenotypic results, which is pretty complicated. So the question that he asked through the consultation service was, what should be done? In other words, what should be the clinical approach given the discordant phenotypic and genotypic susceptibility results in this patient who obviously or appears to have evidence of treatment failure since she hasn't culture converted in 5 months? So what would people on the line do? Would you continue the current regimen based on the phenotypic results, thinking that it's only INH resistant? Would you add moxifloxacin to the first-line regimen to boost the regimen? Or would you treat with an MDR-TB regimen at this point, given that you have mutations showing both isoniazid and rifampin resistance? Okay, let's go ahead and close the poll. Well, I guess most of you could be consultants at one of our regional training and medical consultation centers because that's exactly what the recommendation was. So the consultants at the Regional Training and Medical Consultation Center noted that even with phenotypic evidence of rifampin susceptibility, there's genotypic evidence. In other words, a mutation was found showing resistance to rifampin. So rifampin is likely compromised in this case. The consultant also said that he would obtain second-line drug susceptibility testing right away and treat with an empiric MDR-TB regimen based on these results. And we see this discordance even here at CDC Lab and other labs in our country where there is an evidence of genotypic resistance but not phenotypic. And in this case, I think the really key point is the patient's not doing well. She is bacteriologically still positive, culture positive, and although we weren't given data as to whether her chest X-ray was worse or better or whether she was clinically worse or better, we know that she's bacteriologically failing. The other recommendations by our consultant were to get molecular testing, if at all possible, for fluoroquinolones and aminoglycosides, as our CDC lab now does through their molecular detection of drug-resistant service, and also stated that they may consider using rifampin but not count it as part of the regimen, given that the likelihood that it's effective is low since the patient was still culture positive. Monitor sputum monthly, screen for adverse reactions to second-line agents, and call back if needed. And one thing to note here is that the panel site can call back for ongoing consultation, and if the physician, whoever it is, has called once already, they'll be rerouted to the same consultant, so there's continuity of care. So in this case, I think the panel physician was able to go ahead and treat the patient as if MDR based on the consultation. So let me go on to case number 2 and 3 in the interest of time, and we'll take questions at the end. So this is another consultation that came into one of our regional training and medical consultation centers, 31-year-old female U.S. immigrant visa applicant who's diagnosed with smear-negative, culture-positive, INH-resistant pulmonary tuberculosis. And here's her X-ray, clearly, again, abnormal, showing right lower lobe effusion, pleural effusion, likely with some tracking along here. If you were to get a lateral decubitus, it would probably layer out. And likely a right lower lobe infiltrate as well that might be hidden behind the effusion. So this patient was started on rifampin, pyrazinamide, and ethambutol. She weighed 35 kg, so that rifampin dosage appeared to be correct for her weight. And she was started by directly observed therapy on November 2nd, 2011. Apparently had some nausea after 2 weeks, but didn't report her symptoms until she'd had a month of doses. And when she had her liver function test done, this is actually what was in the consult note, that her SGPT was 35 times the upper normal limit, which I find hard to believe, but that's what the physician reported. So what would be your next step? And again, there's really no correct answer, but just to get us to think about it, would you stop medications, or would you continue medications and follow clinically, or would you consult an expert? And, of course, these aren't mutually exclusive. 1 and 3 could be done as well, but what would be the first thing you would do? I think most people would stop medications given that we have such high elevations in liver function tests. This is the kind of situation in which potentially you get into real trouble with hepatotoxicity and liver failure. So, and of course, consulting an expert would be also a good idea, and I could have put a fourth option of doing both of those things. So the medications were stopped. Once the liver function tests were normalized again, this physician in the panel site restarted medications at a lower dose. I could have put in a polling question here, but just in the interest of time, let me say that to give lower doses of the same medications is generally not what we would do in the face of hepatotoxicity from medications. We would probably more likely stop all medications and restart them sequentially to figure out which medication is causing this, because the likelihood that this patient will again have toxicity is high if the same medications are given. But that's what this panel physician did prior to consulting our training centers. Then again, of course, as we would expect, the liver function tests once again were elevated at 4.5 times the upper normal limit. And I guess at this point, the regimen to be used, and I haven't put it in as a polling question, but clearly at this point, what the panel physician wanted to know when consulting the RTMCC is what would be the next approach and what regimen would be appropriate. So our consultant appropriately stated that they were concerned about the low dose of rifampin, 300 milligrams per day, and stated that if with INH-resistant disease, we don't want to underdose the rifampin and risk the development of further resistance. So rather than just answer the question, generally our consultants through the RTMCCs try to address the whole picture for the patient, and that's why this consultant weighed in on the doses. And also stated that in all likelihood, PZA could be the most likely offender, and as we would do per our guidelines, restart rifampin and ethambutol together, given that ethambutol is not hepatotoxic, and check liver function tests. And if liver function tests remain normal, do not start PZA again, add a fluoroquinolone to boost the regimen, and repeat the drug susceptibility testing to ensure no further acquired resistance. And this patient did well. The liver function abnormalities appeared to be due to PZA. There was actually quite a bit of back and forth between the consultant and the panel physician, and the patient completed treatment and did well. So there are two examples of the kinds of consultations that our regional training and medical consultation centers are getting from overseas sites. So let me move on to case number 3, which is our adoptee case. We have a lot of requests in adoptees overseas from different countries, whether it be China or Ethiopia. These are common places where we get these requests from for waivers for these kids, because kids are considered generally to be non-infectious with Posey bacillary disease. They're not often smear positive with cavitary upper lobe disease as adults are. They often have primary TB, and generally speaking, because they're so much less likely to be infectious, the thought is that the U.S. adoptee, that is the parents that are adopting the child, would rather see the child treated here in the United States than treated overseas to treatment completion. So we get a lot of these requests, and with DGMQ, we listen to each one of these cases or review each one of these cases individually, looking at the circumstances, the x-rays, the amount of treatment given, and make a determination as to whether, from the TB standpoint, we make a determination of whether the child could be infectious, and then DGMQ makes a decision on whether the patient should get a waiver to come to the country early before treatment is completed or not. So here's an example of this a case like this. 2-year-old Chinese adoptee was diagnosed with scrofula, or TB lymphadenitis, in a certain province in China in mid-December 2009. The patient was hospitalized for TB treatment, but not at a panel site facility, had no evaluation for pulmonary TB in the hospital where she was admitted, and the U.S. adoptive parents then arranged for panel site evaluation. January of 2010, the patient was evaluated at the panel site, had a tuberculin skin test that was 16 millimeters, and had a biopsy showing changes consistent with TB from the biopsy. A chest x-ray was performed, which I'll show you in a minute, and gastric aspirates were collected at the panel site. Again, these evaluations are generally done per U.S. standards at panel sites, so gastric aspirates were sent, and the child was returned to her province to continue treatment while waiting for results. So here's the child's x-ray. Again, it's a little difficult perhaps to interpret, but there appears to be some abnormality in the left side, left upper lobe, possibly, here we go, some increased markings and possibly some left lower lobe disease as well, and possibly some calcified mediastinal nodes. So it's definitely an abnormal x-ray, and the laterals here doesn't really add that much but shows similar findings. So interestingly enough, all 3 of the gastric aspirates were smear negative but ended up being culture positive. And the drug susceptibility test results showed resistance to all first-line drugs and streptomycin, and were performed twice to verify that there wasn't any kind of an error. So it was pretty clear that the child had MDR-TB. So what might be your next steps here? Stop the first-line drugs, obtain second-line drug susceptibility tests, start an expanded MDR-TB regimen, refer back to the panel site for treatment, and, of course, all of the above is one of the choices, or no vote. All of you could be the RTMCC consultants, I suppose, because I agree with all of the above. So in this case, the patient actually completed the initiation phase of TB treatment at her hospital in her province because the results weren't available yet, that the patient had extensive resistance, but was reevaluated at the panel site February 25th of 2010. At the time, it was about 10 kgs, was found to have 2 red swollen left supraclavicular lymph nodes that were 3 by 9. I'm not sure that's centimeters. I think it was transcribed incorrectly, probably not that big, but that's what was said in the panel physician's note. Asymptomatic per the adoptive family, and another chest x-ray was obtained, was felt by the panel physician to be largely unchanged. This could just be as a result of the technique, but it really does appear that there is an abnormality in this area still. And the patient had not been on an MDR regimen yet, so it could even be a little bit worse, but the panel physician thought it was about the same. Here's a lateral that doesn't add much. Second-line drug susceptibility testing was ordered, and the patient was placed on a pretty reasonable MDR-TB regimen, including an injectable, fluoroquinolone, and 3 other drugs that the isolate was likely to be susceptible to, including linezolid, which is a pretty fairly expensive and effective drug that we use here in the United States. So it was a good regimen. The patient also, being a 2-year-old, had a head CT and a lumbar puncture. Both were considered to be normal. In this particular laboratory, 4 white blood cells was considered normal. And the head CT was normal. But the gastric aspirate smear taken in March 9th, 2010 was still positive. And the patient continued to be asymptomatic and was actually accepted by the receiving county of origin in the United States where the parents, the adopting parents, lived. So that's one requirement, that they need to be accepted by the receiving jurisdiction. So in this case, the patient has not been in appropriate treatment for the 2 months that she's been on treatment. She still has a positive gastric aspirate smear, but is asymptomatic. You probably don't have the data to make the decision, but would you think a waiver for immigration right away should be granted for this child? In other words, what's the likelihood that the child is infectious, and what's the likelihood that the child will have optimal care in the receiving jurisdiction rather than in the panel site? I mean, I suppose the way to look at it is what would be best for the child is the way to look at this, I suppose. That there were no sputum specimens to guide the decision, but that the likelihood is very, very low that this child would be infectious, and the Division for Global Migration and Quarantine then made the decision to grant this child a waiver, and the immigration to the United States was expedited. And again, the reason was to ensure the best treatment within the care of the adopting parents for the patient. So I'll stop there and see if there's any questions. Those are the case presentations.
Thank you, Sundari, for these great examples of the kinds of cases presenting at panel sites. I did also want to introduce Mr. Phil Lowenthal, who will be joining the discussion period. Phil is an epidemiologist with the Surveillance and Epidemiology section in the Tuberculosis Control Branch at the California Department of Public Health. He was involved in the piloting of these new TB technical instructions in California and is here and available to provide his insights on the field experience with these instructions. So let me pose the first question, one of the first questions that we received. And Sundari, I think this can go to you. Are there any plans to use Gene Xpert to screen all culture-positive applicants?
Yeah, that's actually a great question, and since it's an implementation question,
okay,
I'm going to send that to Drew, because Drew, you would know.
Thank you.
Yes, I can answer that, and I agree. It's a great question and something that we get asked about a lot and gets discussed. So right now, the panel physicians, one part of your question, they are able to use molecular tests such as Gene Xpert or the Hain line probe assay, and some panel sites do as it pertains to running those tests to try to get an earlier indication if someone may have multi-drug resistant tuberculosis, and by having an earlier diagnosis, get either the full second-line DST and folks on treatment sooner. But at this point, we don't allow those tests to be used in lieu of cultures for the purpose of screening or clearing someone in order to obtain a visa. And the reason is because of the fact that there is a drop-off in sensitivity between liquid cultures and the Gene Xpert test. So for now, we still require the cultures for clearance purposes to get the visa.
Thank you very much. Another question that came in via the internet, or perhaps it's more of a comment, and that is that many immigrants say their chest x-rays were taken by immigration officials upon arrival, and additionally, there is they don't usually come with their drug susceptibility tests. Can you comment on that?
This is Drew. I can comment on that. That is good to know that occasionally we do hear about persons saying their chest x-rays are taken by the folks at the port of entry, specifically the Customs and Border Patrol officers when they immigrate, and so we can follow up and try to get that reminder out to those officers again that they should not be taking those films. And just so folks know, persons may arrive with either their plain chest x-ray film, or if it's a location using digital x-rays, they may have a CD with them. And in terms of not having drug susceptibility testing results, that's something, if we know of specific instances, that's a little better to target, because the panel physicians are supposed to include that with their medical information. And so if anyone does see a trend unique to one country or a few countries, can always let us know, and we can follow up directly with those programs overseas to make sure that is included.
Excellent. Thank you very much. Go ahead.
Hi, this is Dr. Clark. In mention to what you said about patients coming, I haven't had many patients that are active TB, but a lot of them have had their physical and everything done and their chest x-ray automatically done before leaving the country to come into the United States, but they don't come with any paperwork. So then we have to do it again when we find out that their quantiferon's positive or their PPD's positive. And that surprises me, because they actually were positive. If they're positive here, only being here a couple of months, then they were positive when they left their country, if they had been tested instead of just having a chest x-ray done. And they state that they only had a chest x-ray done. They're not aware that they had a blood test or a PPD test. So I'm not sure if they're screening them that way, just saying, okay, well, your chest x-ray is fine when you come here. And they're very resistant to want to go on latent TB medication because no one explained it to them.
So this is Drew. I think that's a great point, and a couple things come to mind.
Mm-hmm.
As Sundari went through, from what you said, a few things could be at play, and I'll just try to go through them in no particular order. But from what Dr. Mace described, the skin testing in IGRA overseas is only done for the applicants 2 through 14 years of age, where the TB rate in country is at least 20 per 100,000 or greater. So persons 15 and up would only get an X-ray, and you're absolutely right, they would not get a skin test or an IGRA test done. The other thing that comes to mind from what you're describing is in the notification system for EDN, that whole apparatus, EDN does notifications for all arriving refugees, regardless of their examination findings. All 50,000 or more refugees who arrive each year, there's a notification in EDN. However, for the immigrants, notifications are only done if there was a TB classification on the overseas exam. And so I mention that because you mentioned folks coming and not having paperwork on them. If by chance you're seeing someone who did not have a TB classification overseas, meaning someone who had a normal exam basically, there would not be a notification on them if they were an immigrant. I don't know if that information is helpful.
No, it's helpful. I have one quickly. I know other people have questions. One is a question for Dr. Mace about the genotype, phenotype with the case that you presented. If the genotype was resistant, then unless you have funding or something, why would someone necessarily do the phenotype, especially if you know that you're most likely going to not treat them with the 2 resistant medications? And then my second comment, before you answer that, is that I actually am concerned sometimes with my patients who are domestic American patients and some immigrants who have been in the United States for a long time and treated, because what I'm finding is that they are at risk for TB, but when people aren't looking at that, they're asking them questions for college and for school, and if they answer no to it, if at the bottom of the line of the college form or the school form it comes out that all the questions were answered no, they don't need a TB test. Yet when they come to me to now fill out their green card, I'm telling them they need one. And actually, when I look into their risk factors, they should have had one. I'm not sure who's making up these forms for college and school here.
Right. Great questions. First of all, there are instances where you can have genotypic resistance, but it's a silent mutation, and it doesn't confer phenotypic resistance.
Right.
And we have those cases. They're rare, but I think really having both tests is appropriate to kind of dictate how to proceed, and then looking at the patient to see how they're doing. In this case, I think the key thing was the patient wasn't doing well, and so you would want to go with the test showing resistance simply because she was acting as if she was resistant. So using both tests is appropriate. In this case, it was great the panel site could actually have access to the molecular testing method. Now, the second question, in colleges and schools, generally we do try to prioritize patients based on the initial questions before testing them because it's a way of performing targeted testing. And yes, you're going to miss certain numbers of people by doing it that way, but the data suggests that just screening everybody who enters college or who is in certain grade in school isn't really cost effective and doesn't lead to greater detection of real LTBI or for case finding. So that's the reason why that exists. But of course, when you see them for green card and elicit other risk factors, it's appropriate then to test them and proceed as you would otherwise.
And I'm also a primary care, so it's hard when you see a patient who was treated for active TB in California move to Connecticut, and you find out, wait a second, what do you mean your wife was never tested?
Right.
He was getting the treatment quarantined at home. So, yeah, when I tested her now, she's positive. Of course, she was probably positive 5 years ago when he was being treated. So people are getting missed in the in regular everyday life system that should be tested. Thank you, though.
Thank you. Thank you. We have a question about children, and that question is, and perhaps, Phil, you could share your California experience about this. In the case of a child, is this child that you are notified about with LTBI, are they showing up at local health departments, or do you find that they're going to primary care physicians?
Hi, yeah. So we've found with the 2 to 14-year-old children who arrive with the B2 LTBI classifications that they're primarily showing up at the local health departments. The health departments are actively going and contacting arrivers who have a B classification. They're of course prioritizing persons who are TB suspects who had an abnormal chest X-ray on their overseas screening, but some health departments, depending upon staffing and resources, are also contacting and scheduling follow-up evaluations with the B2 latent TB infection arrivers.
And there's a follow-up to that question, which is, so in the as you are following up on these children, if they were under the care of a private provider, have you found that to be acceptable if you receive the information?
That's been the main challenge is getting the information transmitted from a private provider to the health department. But yeah, that's acceptable from the state health department perspective.
Excellent, thank you. Another question that has come in online relates to the HIV status. The questioner understood that HIV screening was no longer conducted for immigration purposes, and if that's the case, how is the co-infection status determined?
This is Drew. I can take that. So it's a great question, and the person who asked the question is absolutely right that HIV testing is no longer a required component of the medical examination. What we have told panel physicians who are, by and large, well aware that it's an important risk factor for TB and important to know about someone's HIV status, is that when they diagnose someone with tuberculosis disease, they should counsel that person about the importance of HIV testing and offer that testing, but it is up to the applicant as to whether they get that testing done and then where they have that testing. But there is counseling regarding HIV status for all the TB cases.
Excellent. Thank you. Yes, go ahead, Mark.
Yeah, hi. Drew, this question's for you. We had this year an 11-year-old adoptee from China who had pulmonary tuberculosis, was evaluated by the panel physician, put on 4 drugs, and for whatever reason, because she was living in an orphanage, the local doctor continued treatment. And so when we had worked with DGMQ, agreed that she was not infectious, but in review of her treatment records, there was some interruptions. There was a period of time where she was only on INH and rifampin during the induction phase. And so, and we were able to get the records from the treating physician, but not totally figure out the reasoning for this treatment. And so I guess my question is there a requirement that the person's treatment be under the either direct management or at least consultation by the panel physicians? Because, we had difficulty in putting together a regimen once she got here, and I'm not sure, why her treatment was handed back to a local physician by the panel physician, or seemingly.
This is Drew. It's a great question. And so the DOT requirement in the technical instructions is that someone receive treatment according to a rigorous DOT standard. It can be done more than one way. There are programs such as the Philippines, which got discussed, where they have a DOT program in-house. It can be done, as what was mentioned, with the Dominican Republic. I referenced their public-private partnership, where it is actually the National TB program that is providing the directly observed therapy, or other, there's a range in terms of other clinics that are able to do this that the panel physicians work with, the key being the rigorous requirement. So I hope that is helpful. On your specific case, unfortunately, I can't recall the specifics of that, but from what you're describing, maybe offline, I'd be interested in knowing more about that scenario so that we can provide any follow-up in China that might be appropriate.
Yeah, I don't think the question was the DOT, since she was in an orphanage, so much as the drugs that were being used for the treatment. But I got the records through your division, so I can send them to you.
Yeah, and the programs are supposed to use regimens that follow the CDC, IDSA, ATS guidelines. So,
okay,
and that's a firm requirement for the programs overseas.
Mm-hmm.
Thank you. Go ahead, Peter.
Hi. First question is, I'm curious, why were the 1991 technical instructions so lax to begin with? I think Dr. Mace did a really good job of summarizing and really highlighting some considerable weaknesses. And I'm just curious why, I've always been curious why those guidelines were, kind of very broad to begin with. And then also the second was more detailed with the case presentation number 1. Do you know what the concentration of rifampin would have been in the overseas drug susceptibility testing? Because I know when we've been presented with discordant phenotypic versus genotypic results, that's kind of a question that comes up. Is it depending on which laboratory you're looking at, you could well be testing at a lower concentration of rifampin, where genetically you observe a change in the DNA sequence, but if you're not really challenging the organism phenotypically, it appears to be,
it could appear to be susceptible, right? Let me take the second question, and Drew can take the first. But I'm not sure exactly what concentrations it's tested at, but I know that.
Sense also just, do you know that they're using the same standards that we would hear? That's
right. Drew may be better to speak to that as well, because these labs that are being have quality control overseas, and they are supposed to be using the kind of standards that our labs do. So, Drew, maybe you can weigh in.
No, you're exactly right, that we are striving for very rigorous labs overseas.
And the testing is very similar. Even here in our country, different labs test drugs with different methods and different concentrations, and that's why we have discordance often. So your point is well taken, but I think there's some fairly standard concentrations that rifampin is tested at, like any drug. So probably at, I don't know, I want to say maybe at 1, and I'm not sure. I'll have to go back and look. But we do have instances, though, that we have this discordance that we see even here at CDC Lab that's real, and then you really have to look at the individual patient to try to make a decision how to treat them. And Drew, with the first question, did you want to answer that?
Absolutely, and it's a great question. And if I'm paraphrasing correctly, it's the 1991 TB technical instructions. Why were they so lax and broad? My understanding is in 1991 when those came out, maybe that those were pretty good, but over the years we did let them get lax and didn't keep up with the modern standards of care, particularly on the culture front. And even though we're talking about, this time period of sort of 2005 to 7 in terms of developing these technical instructions and starting to implement them, there was a recognition before then that a smear-only system was probably inadequate and insensitive, and that helped form some of the impetus of the Vietnam study that Sundari mentioned, done by DGMQ and DTBE, that had a publication date of 2006, but as we know that, the work then would have transpired well before that, and that was the case with that study. So there was, I can't speak to, what exactly the tenor was in 91, but as the years went on, there was a definite recognition that they were likely inadequate, which led to a study and work being done, and the weight of evidence just became clear. We needed to try to make that change and then try to implement it.
Yeah, and if I can just add that the amount of resources that DGMQ has put into establishing the ability to do cultures like this overseas is incredible, and being able to have quality control for the cultures and drug susceptibility testing, it's been a monumental task. And I think back in 1991, the thought was, well, let's just find the most infectious patients and make sure they're treated. And now, of course, the objective is to find all infectious patients and ensure treatment and ensure that that as few as possible are going to fall through the cracks. So it's a different standard that we have now, too, I think.
Thanks.
Okay, thank you very much. I would like to thank our great faculty for this webinar. Thanks to Dr. Sundari Mace. Thank you to Drew Posey, and thanks to Phil Lowenthal for sharing his California experience. Thanks for joining us today, and have a good afternoon.